Dear students, we are in the third part of the wrist and hand complex. So, continuing from the second part, the so-called meniscus homologue is a region of irregular connective tissues that lies within and is part of the lower lamina. So, we have already talked about the upper lamina and the lower lamina. The dorsal and the volar radio-ulnar ligaments are part of the upper lamina, and then we talked about the other ligaments which are also part of the lower lamina. The meniscus homologue is another region with irregular connective tissue which is part of the lower lamina, which traverses means which crosses volarly and ulnarly from the dorsal radius to insert on the tracheuterum. Dorsal radius to tracheuterum is the orientation of the meniscus homologue. Along its path, the meniscus homologue has fibers that insert into the ulnar styloid and contribute to the formation of the pre-styloid recess. The TFCC should be considered to function at the wrist as an extension of the distal radius, just as it does at the distal radioulnar joint. So TFCC we can be considering as a extension of both the distal radius and the distal ulna. The scaphoid, lunate, tracheuterum, that is a three proximal carpal bones. Even pisiform is also included in that, but here because they are covered totally by the soft tissue structures, the proximal carpal row. When you study anatomy, you also have to write the pisiform. But biomechanically, it is considered these only three bones: scaphoid, lunate, and tracheuterum, having the uh, what you call as the biomechanical importance. The proximal carpal row articulates with the distal radius. These three bones articulates with the distal radius. These bones are interconnected by two ligaments that, like the carpals themselves, are covered with cartilage proximally. They are the scapholunate interosseous and the lunotracheutral interosseous ligaments. They are the scapholunate means ligament between scaphoid and lunate interosseous, that is, and the lunotracheutral between the lunate and the tracheutral bones. So scaphoid to lunate to tracheutral. These three interosseous ligaments are respectively. The pisiform anatomically is part of the proximal row, does not participate in the radiocarpal articulation. As I have already mentioned, the pisiform functions entirely as a sesamoid. The pisiform bone is a sesamoid bone, like the patella. Like the patella, the pisiform is a sesamoid bone, presumably to increase the momentum. If you see the patella of the knee joint, the biomechanically, it increases the momentum acting like a pulley system. So here the pisiform is also a sesamoid bone. That the function is also to increase the momentum of which muscle. I already showed in the earlier picture, the FCU, the tendon sheath which is traveling. So it is attaching to the pisiform, the flexor carpi ulnaris sheath, and the tendon it envelops the flexor carp, the tracheal bone. Sorry, the pisiform bone. The FCU envelops the sheath, envelops the tendon, and also it is covering the whole soft tissue structure is covering the pisiform. The length of the ulna in relation to the radius is also a factor. Now, next area we are going to discuss about the length difference of radius and ulna. How the depending on the length of the radius and ulna comparatively, we have two variances called as ulnar negative and ulnar positive variance. The ulnar negative variance is described as a short ulna in comparison with the radius at their distal ends. If the ulna's length is shorter than the radius, we call it as uh, ulnar negative. If the ulna's length is equal or longer than the radius, it is called as the ulnar positive. See, in this picture, you can see this is the radius, this is ulna. If you draw a line from this part of the ulna, this is the this line, and then you see the radius is comparatively higher than the ulna. So we will call this as, because an ulna is lesser, negative ulna. So negative ulnar variance. Here it is almost equal, or make come slightly if the ulna is slightly projecting above the radial surface, the articulating surface area. The proximal articulating surface is comparatively, the ulna is equal. So here we will call it as positive ulnar variance. Negative ulnar variance when the ulnar articulating surfaces, that is the total length of the ulna, is comparatively lesser than the radius. Negative ulnar variance. This is positive ulnar variance. When an axial, that is longitudinal or compressive, that is axial load is applied, if it is tensile load, it has to be distraction. So here we are talking about compressive load. Longitudinal compressive load is applied to the wrist. The scaphoid and the lunate receive approximately 80% of the load. So that you have to understand that whenever we are using our hand to do any kind of loading activity, when we are using to any load, compressive load comes to the hand, scaphoid and lunate is taking 80% of the load. Rest is what, which bone we have, tracheotoral and pisiform. So that actually the attachment is actually TFCC is taking the other load, because the importance of the bone pisiform is not at all there, and tracheotomy does not take, only take 20%. So the overall TFCC which is present in that area takes the rest of 20% of load. So that means scaphoid and lunate is a weight bearing bone compared to, in the proximal row, compared to that of tracheotomy and pisiform. At the distal radius, 70% of the contact is made with the scaphoid and 40% with the lunate, such as ulnar shortening to unload the ulnar side of the list. So at the distal radius, when we compare both scaphoid and lunate, the scaphoid takes more, 60% of that of the lunate. That is what we should understand. In contrast to ulnar positive variance, ulnar negative variance, a relatively short ulna, may result in abnormal force distribution across the radiocarpal joint with potential degeneration at the radiocarpal joint. So why did we study? We already studied the ulnar positive variance and negative variance. So relatively, that is a smaller ulna will create, what will it create? It will create a shorter ulna, may result in abnormal force distribution across the radiocarpal joint with potential degeneration of the radio. So abnormal weight distribution will happen mostly in negative ulnar variants, and therefore this will create immense pressure on the bones. So naturally the weight transferred through the ulnar side will be affected, and this will lead to avascular change. Avascular means difficulty or abnormality in the vascular supply, blood supply to the bone and to the structures which is been supplied by proper arterial supply. So here you can see the scaphoid, lunate, tracheotomy, trapezium, trapezoid, capitate, and ham. Capitate is a larger bone here, and you can see the scaphoid. The pisiform is actually enclosed here. It's not inside in the the soft tissue structures. And here you can see, here if you see, it is white. It is white here, comparatively white here, and mild vascular necrosis in this part, and also somewhat in this area. But here if you see, the lunate bone is totally gone. It's darker, degenerated. So the bone is, the what you see white is a good healthy bone, which is a presence of more calcium, and which is opaque during the X-ray, when X-ray passes through. Here you don't see the osteo blastic or clastic activity. Here you can see degeneration of the lunate bone. The avascular necrosis of the lunate bone, that is otherwise called as the Cane box disease, has been associated with negative ulnar variants. What will happen in negative ulnar variants? There will be abnormal transmission of load during compression activities. So that will lead to increased load on the lunate surface, because the negative ulnar variants there will be no transmission of weight through the TFCC. So most of the weight will be transmitted through the radius from this side. So here there is no transmission. Soft tissue structure, it will be pliable. So weight will be transmitted from this area. Constant compression or through the middle area of the wrist will lead to compression and injury to the lunate bone, lesser circulation of the bone leading to avascular necrosis due to lack of blood supply. Without no not without any blood supply, avascular vessel is not working. So there is avascular necrosis, degeneration of the necrosis or degeneration of the death of the bone cells. It's called as Cane box disease. Why does it happen? Negative ulnar variance. What is negative ulnar variance? The negative ulnar variance is when the length of the ulnar is comparatively lesser than that of the radius. The flexor carpi ulnaris is the only muscle that crosses the radiocarpal joint and attaches to any of the bones of the proximal carpal row. When you're talking about the this joint, radiocarpal joint, the only the muscle which is actually the tendon of the muscle which is crossing through the joint is the FCU, the flexor carpi ulnaris, and which has attachment to the pisiform and the pisiform bone, and the in a way it has attachment to the TFCC, so we can say it has attachment to the ulna as well as to the tracheal bone. Now we're coming to the mid-carpal joint. Actually, we did not discuss about the more about the ligaments in the proximal radiocarpal joint, because all the ligaments are same as that ligament which are present in the mid-carpal. So here the ligaments we will discuss together in the mid-carpal joint. We will discuss here when we will discuss it as the extrinsic and intrinsic muscles. Sorry, ligaments of the and we also have extrinsic and intrinsic muscles also in the hand. So here the ligaments we will discuss only together we will discuss it in the midcarpal joint structure, because you will be wondering why I did not talk about any of the ligament in the radiocarpal, even though I have described it. We did not talk more about it. So in the midcarpal joint structure, now we are coming to the midcarpal joint, which is actually the joint between the carpal bones. The midcarpal joint, that is a joint between the proximal and row and the distal row of the carpal bones. The midcarpal joint is the articulation between the scaphoid, lunate, tricutum proximally and the distal carpal row composed of the trapezium, trapezoid, capitate and hamate. The midcarpal joint is a functional rather than an anatomical unit because it does not form a single uninterrupted articular surface. You cannot put the midcarpal joint into a very perfect anatomical joint, because it does not is not at all like that. It is not a single uninterrupted does not form a single joint. It is actually a lot of small carpal bones together, with lot of interattachments, interjoints, but basically functioning as a single unit to have a good hand function. However, it is anatomically separate from the radiocarpal joint and has a capsule and synovial lining that is continuous with each intercarpal articulations and may be continuous with some of the carpometacarpal CMC joint, that is the next joint, the distal joint. So when we take the radiocarpal joint, the capsule is comparatively loose, and the ligaments of the radiocarpal joint are similar to that of the midcarpal joint. That's why we'll discuss it here. So here in the radiocarpal joint, the difference is the only way we can say that the midcarpal joint is different from radiocarpal joint is only reason is that the capsule for the radiocarpal joint and the capsule for midcarpal joint, synovial capsule I'm talking about, is totally a separate synovial capsule. The radiocarpal synovial